Here we all are together about a very serious topic, and we thank our Synod COVID team for being a part of this presentation tonight. And as they present, they will introduce themselves and tell you a little bit about themselves so you have a sense of who they are. Bishop Aiken had put together this Synod SMART team, COVID team, so that for any Synod events that we hosted, that we would have an ability to have a ready bench, so to speak, to help us think through some of the tasks before us as we prepare for Synod events. But as we continue on, probably longer than any of us had anticipated that this virus would take us, we're going to pull from the expertise and understanding and knowledge of our Synod COVID team to do a little presentation tonight and then answer some questions that you might have. Deacon Brenda Tibbetts and I will be monitoring the chat box, and so we invite you to put your questions into that chat box, and we will get to that quickly and pass that on to our panel. But I want to begin tonight first by reading from the 6th chapter of Isaiah. The Spirit of the Lord God is upon me, because the Lord has anointed me. He has sent me to bring good news to the oppressed, to bind up the brokenhearted, to proclaim liberty to the captives and release to the prisoners, to proclaim the year of the Lord's favor. Jesus read this Isaiah text aloud at the beginning of his ministry, and he invited the disciples to join him in healing, in blessing, and in ministry. And he invited his disciples to join him in this very active ministry in ending oppression. Even Jesus could not live the fullness of life that God had intended for him unless he worked for the fullness of life of all. And so here we are as the church gathered together, a people who need liberation and people who work for the liberation of others, and all receive the gift of living in the freedom of God's grace in Christ. Let us pray. Good and gracious God, God of liberating grace, set us free from complacent and uncaring hearts so that we can set others free to live a blessed life together in you. We pray for your presence to be with us this night as we struggle to understand, as we think of our own contexts and cope with this virus. Remind us of your presence so that we might be the people that you need us to be in this world that so desperately needs to hear a word of love and grace and hope. In your holy name we pray. Amen. And so at this time, I turn it over then to Kim Donner. And Kim, just a little introduction, and then feel free to jump in.
Hi, everybody. My name's Kim Downer, and I am a member of the Lutheran Church of the Good Shepherd in Duluth, Minnesota, and got involved with their SMART team over the summer, actually, and was asked then to join the SMART team for the Synod. My day job is a professor of healthcare management at University of Minnesota Duluth. And I have a background in public health. And so we thought we'd start tonight with some slides related to the data and the trends related to COVID in Minnesota. So I'm going to share a couple of slides with you and talk kind of big picture on what the numbers are doing right now. And this is something I do regularly with the Good Shepherd SMART team. And so if they're on the call, this will be familiar. Okay. Now I need to. Okay, so hopefully you can all see Right now, my slide's up there. In terms of what's going on nationally, just to put it, and internationally, just to put it into context, we're getting close to 75 million cases globally. And as of today, we reached 17 million cases in the United States, with the United States making up about 23% of the global total. In Minnesota, we're approaching 400,000 cases. The numbers today put us slightly under that at around 389 to 390,000 cases. This turns out to be, on average, 575 new cases per 1 million population in the state every day. The good news is these numbers are starting to trend down. And with that average daily number of new cases being at its lowest point since early November. The same trend is holding true in northeastern Minnesota. And more good news is that hospitalizations are down, but intensive care units are at about 80% occupancy right now, and that's for the state. And so those numbers are not that wonderful. This is a big graph, but it shows you the history of cases in Minnesota. And if you look to the far right, you see that number continues to track upward. And that darkest red indicating most transmission within the state. And that number has been high, as you can see, since about mid-October. Looking at how this breaks down by county, again, red indicating the greatest risk of transmission, the highest risk of spread based on the number of cases per population. And so you can see most of the state, except for Cook County, is in that high risk category. John sent me this information just as we were getting ready to go live here at 7 o'clock. And this is the test positivity rate by county for the Synod, for the counties that make up our region. And the thing to notice here is that higher numbers, or higher percent test positivity indicates that we're probably not testing enough people to pick up kind of every possible route of transmission. There's likely more people in the community who have COVID that we're not testing. And you can see I've highlighted in red the counties that are nearing 20% or over 20%, with Kennebec County being at a high of 26.2%. Most of the researchers at CDC want this number to be below 5%. And so it's still very, very high. Even looking at Cook County, it's still up above 5%. So indicative of a lot of spread out there that we're not catching. And as you probably all know, the governor yesterday continued restrictions on bars and indoor dining and gyms with the hopes of furthering the decrease in transmission across the state. Some areas of concern that John and Kathleen are going to talk about are and that we can get to in the questions, that nursing homes still are seeing outbreaks quite regularly. We can talk a little bit about vaccine delivery and distribution. And just as a reminder that even with the vaccine, there's still an increased need to wear the face masks, to continue to physically distance ourselves. And just a general reminder that there's a lot with COVID we really don't know. There's more and more research coming out every day, and we're learning more, but there's still a lot of things that we don't know. So thank you.
Okay, I'm going to go next, and I'm Kathleen Axtell, and I'm a member of Grace Lutheran in Hermantown. My background is that I'm a registered nurse who's also a public health nurse. I worked with both for St. Louis County and the Minnesota Department of Health. And I was a clinical instructor of public health at Scholastica. So my background is mostly in public health and all the different facets of it. and not, you take that general knowledge and apply it to each new situation, and the new situation now is COVID. I'm on the SMART team at Grace Lutheran and wrote their COVID-19 response plan and the guidelines for when we would open, how we would open, and how that whole format would go. I've written guidelines for phase 1 and 2, but not for 3. So as you all know in the news, 2 vaccines have now been approved for distribution. The Pfizer vaccine last week and the Moderna vaccine today. And it takes a while for vaccines to be approved, both once they've completed their 3 trials of phase 1, 2, and 3. Then APEC or ACEP, which is the Advisory Committee on Immunization, reviews all of that information. They make a recommendation to the FDA to approve it. The FDA reviews some information and they approve it, and finally CDC gives it the go-ahead. So it needs to go through all those steps so that individuals are assured that all the data was looked at, that each phase of the clinical trials was complete and wasn't rushed, and that they looked at potential problems. Along with that, then APEC and the CDC actually write some general guidelines for distribution of who should get the vaccine first, and I'll go into that a little bit. The initial phase is going to be 1A, and we're already into that, and it's healthcare personnel are the individuals that will receive the vaccine first. And healthcare personnel are defined as paid and unpaid people serving in healthcare settings who have the potential for direct or indirect exposure to patients or being present with infectious material. Long-term care residents are defined as adults who reside in facilities that provide a variety of service, that receive a variety of services, including medical and personal care, who are unable to live independently. And these 2 groups have been prioritized for a variety of reasons. We need our medical personnel to be healthy and safe, and they cannot be contracting COVID at high rates, because who is going to care for our patients on COVID wards, in intensive care units, and just the regular patients that find themselves in the emergency room or in the hospital for routine care. We already know that nursing home residents are at risk for greater fatality from the COVID. So the next group that we would want to protect are those. And so they make those recommendations based on ethical principles, that everybody would have the same access. So they look at, who's at most need, and then they look at, are there any groups in our population that are also at risk? Another group that would be second to receive the vaccine are essential workers. And that's defined very broadly. Policemen, firemen, EMS people. In some communities, it may be transportation workers, because large cities, you can't get around without transportation. People who maintain our power grid, teachers. So that's a little bit harder to solve of who are our essential personnel. And then after that, high risk individuals and those over 65. So the type of vaccine that has been made for the COVID is known as an mRNA. And that's a specific type of vaccine that has been developed. And although people think it's relatively new, the structure for it is not. We first became aware of it probably in 2003 with the SARS outbreak, and human trials have been initiated as early as 2011 for cancer vaccines. So we were familiar with the structure of the SARS-CoV virus, but we didn't have the specific template for that until China released their data on it, and then vaccine companies could begin making the vaccine, and they could speed up their response by making the vaccine ahead of time, which was a financial risk, because if the vaccine didn't work, then they had to throw it all out. But if it did work and met the protocols that they would say would benefit giving the vaccine, then they already had it made and they didn't have that downtime. And that's why the vaccine is so readily accessible on an earlier timeline than it normally would have been. And I could go into a lot more detail, but I think I'll stop at that point. You might have questions later on.
Yeah, Kathleen, there was a question regarding sharing the document of Grace Lutheran's open plan, and it was highlighted that there are a number of smart plans that are on our Synod website. And so if people have trouble finding that, you can simply put smart plans in the search bar, and you will come up with quite a few plans that have been given over to the Synod office. So I want to let folks know that, and there is a template here too.
Yeah, and I don't know that, I'm not sure if my plan, it was right when Bishop Aiken was leaving that I sent mine in, and I just sent it to you this week. So I don't know if it's been put on the web.
Yeah.
Okay.
Yeah, we'll get it on the website, but I do want to point that out to everyone that there are quite a few there as examples, and there's a template for your assistance too. Thank you, Kathleen.
I'm John Moe. I'm at Trinity in Hovland. I am a registered nurse. I also am working at the North Shore Health in Grand Marais. I'm the educator up there. My background has been a lot of nursing education, both staff development, academic education, and then clinical. Right now, I get involved because with all the changes, I pulled in a lot as things change because of the education side. But that also makes me aware of a lot of the other effects that this has. And we look and talk about the number of rates, but I had given Kim the positivity rates for our Synod, and this is coming from Medicare. And so this is kind of a collateral side to that. Those numbers are of major importance to all of our long-term care facilities. Medicare, in its wonderful oversight wisdom, has said that all long-term care facilities must test their staff, their volunteers, their essential caregivers for COVID based on your county's positivity rate as they determine it. So we can't look at the state, we have to look to Medicare. And they give us 3 categories: an under 5%, a 5 to 10%, and a greater than 10%. Well, that translates into testing. In that low level, we only test people once a month. In that middle range, that 5 to 10% range, at long-term care, we're being tested once a week. For the people over 10%, if you work at long-term care, if you volunteer, you are now subject to COVID testing twice a week. Now, how many of you have had a COVID test? So quite a few. How often would you like to have that done? This is one of those collateral pieces that we don't realize that how behavior affects. As our positivity rate gets up, everyone working in long-term care is subject to testing. I have gone myself, I looked up the numbers. I've been tested 10 times this fall. And I was so hopeful. Our numbers dropped. We weren't going to be tested till January. Our numbers went up. I'm being tested again next week. So it changes. 1 week we were at twice a week. Now we went to once. We had a week's break. We're going back to once a week testing. So I see that aspect, and that's truly that collateral of people's behavior, not controlling the spread. We pay a lot of attention to the vaccines, how they're coming out, how the distribution plan is. And so I get to look at this from a lot of places. But I think I was more thinking, what are the questions that people have? And Bishop Amy, I'll turn it over to you then.
All right. Well, I think that thank you, panel, for offering your insights and expertise. And at this point, we want to hear from you. We want to hear what questions you might have, what's on your mind, while we have our Synod team available to help try and answer some of those questions. So I invite you to put those questions in the chat box. Sounds like someone's unmuting themselves, and that's fine. Speak up then too. No question is a silly question unless it goes unasked. Oh, here we go.
There's two questions on here right now, Bishop Amy. Jill from First and Aiken, where do pastors and church staff fall in line up for vaccines? And from Robin down in Mora, when should a church have Sunday service? I'm assuming in person is part of Robin's question.
When would those individuals qualify for vaccines? I think they would follow the guidelines of who they are. So if you're a person over 65, you'll fall in that category. When we get to that phase of administering those vaccines, if you're a younger person, you'll have to wait until all the other categories have been vaccinated before you become before vaccine becomes available for you, unless you have a chronic condition or a health condition that makes you at risk for having a severe case of COVID and possibly dying from it. Then you fall into that other category.
And I would add on that when we look at the pecking order for the vaccine coming out, and it's going to come out in basically small numbers and around the state. In Minnesota, it is the Minnesota Department of Health that is going to determine the priority orders of people for who they're going to get it. But in terms of general public, we are still looking probably late spring to summer for general vaccination.
Yeah, I posted a resource for everyone. That the New York Times has a little online thing where you can post, or you can put in your age, your occupation, and it spits out an approximation, not taking into account some of those factors related to the state that John just mentioned. But for example, I put myself in, and my date was the end of May. And I fall in the category of a teacher. So maybe priority, I don't know, but toward the end, because I'm not a K-12 teacher, I put in my spouse's information, and he was sometime in June. He's not an essential worker. So, you know, it's going to vary, but I think John's assessment of spring is fairly accurate. And Kathleen did a good job kind of outlining the various individual risks at play.
Yeah, the APIC and CDC issued guidelines to the state, and then the state has the ability to refine it themselves, because each state is a little bit different. But if you feel you're an at-risk candidate for morbidity from COVID, you know, that's something you should discuss with your physician if possible. And they probably would then recommend you for a vaccination. I guess maybe where they're not considering ministerial staff as essential workers at this point. But
Bishop Amy, there are a number of new questions coming in on the chat.
Yes, and I see that there's a lot about in-person worshiping. And so I think Kathleen, maybe you can speak to that as a SMART team member. What are the things that you took into consideration?
okay,
I
well,
think
there
it's
were
guidelines to help people
two
think.
things in our church I looked at. One, I wanted to see better air exchange. When we had done an addition to our church, somebody had eliminated air exchange, which is the worst thing you could do for COVID. You need to have good, adequate air exchange to ensure that the virus isn't hanging in the air, whether it's in the droplet form or the aerosolized form. You don't want to be breathing in the virus. So several members of our church got going, and they were able to change our system so that they could get 100% air exchange for at least an hour to an hour and a half without stressing either our heating or cooling system. So once that was done, then I knew that once we met our opening criteria, we could then start meeting in person, but continuing with mask wearing, social distancing. So we would have limited numbers of people within the sanctuary. We would space people 6 feet apart. But we never met that criteria. And the criteria was 2 weeks of a downward trend. And I use St. Louis County's statistics for our planning, and then 2 weeks of stabilization. But we have never met that. We had outdoor services during the summer, so we have not had indoor services. However, we did allow groups of 10 or less to meet over the summer and into the fall, as long as they practiced social distancing, wore a mask. We improved the air exchange to the room that we were meeting in. So I closed off some rooms for meeting. We met in our bigger rooms until we had the air exchange problem solved. I would open all the windows. And there would be no eating. If we were going to eat a snack, and many of our groups, it's a social event to have coffee and something. They're all Scandinavian. We would meet outside for that apart. And then we would come back into our activity. And our small groups all had to be church related, like our quilting group, our widows group, a book club, a Bible study group. So they were all very small groups of 10 or less. So we have not met in person yet. I'm still waiting for the stabilization to take place, and then we'll start meeting in person. But I don't see that throughout the winter months at all. So we have virtual services after we discontinued our outside services because it got too cold.
And Kim, is
My
there
recommendation.
anything?
Pardon?
Thank you, Kathleen. Is there anything you'd like to add, Kim, from being a member of a SMART team?
Yeah, I think so some of the criteria we use are coming from the CDC in terms of proximity and duration of time. So anything 15 minutes or longer within 6 feet of another person is really too much of the possibility that you will be breathing each other's air, and thus raises the potential for infection. So if you are a congregation looking for parameters in terms of how to think about your space, air exchange, like Kathleen mentioned, but also thinking about distance and time as two variables that really need to be considered. And as far as Good Shepherd, the things we've been doing are very similar to what Kathleen mentioned for Grace Lutheran. The other thing we've explored is looking at the criteria through the Minnesota Department of Education for schools in terms of their criteria for what level of schools could be open in terms of community spread. I can go look for their website and post it, but it's listed by county, and then it links to criteria for what schools can be open. And you'd want to look at the category of the older kids, high school, because they're most like an adult population. Smaller kids don't seem to be as affected by COVID-19, and they don't transmit it potentially as much as adults do. And a lot of our congregations do tend to be older, and so we got to take that vulnerability into consideration. But looking at some of the numbers related to schools might be another helpful starting point. And I will say there's like no magical answer for everybody. But I did see one question in the chat about current outbreaks. And that's yes, churches have been hotspots, and they have been, a number of outbreaks have been traced back to churches specifically, and then weddings and funerals more generally, whether they occur in a church or in another setting.
And I just like
I think that,
numbers went
go
up
ahead, Kath.
beginning in October dramatically, and into November, we canceled our small groups. So there's no small groups taking place right now.
And some questions regarding singing and congregational speaking, as well as how do you address folks who still think that this is a hoax and do not want to wear a mask?
To be honest, the people who are thinking it's a hoax and are not going to want to wear a mask, you'll not change their mind. It's going to be very hard. But, two things to back us. One is, number one, it is state law. So we have to wear it. Another thing is that the research that's coming out now, research has always said that it helps to prevent you from transmitting it if you have COVID. But some of the latest research now is actually showing that the masks are actually helping to protect you too. So we're finding it from two things. It's not just preventing transmission, but it does help prevent you from getting the infection. One of the things I want to just say when we were talking about the ventilation, please keep in mind ventilation and air exchange are very different from just air circulation. If all in your church, if all that's really happening is the air is being moved around, that actually makes it more dangerous to open. You need to be bringing in fresh air and getting that fresh air in, getting the stale air out for it to be adequate. And this goes with one of the newest things with the transmission. We've always known the droplet, the aerosolized. But Dr. Mike Osterholm brought this up, is that there is an airborne transmission that they are discovering. And the way he described it was to think of airborne transmission as perfume. You are walking into a department store. How far away from that perfume counter do you need to be before you can start to smell it? It's more than 6 feet away. And that's what one of the things they've been finding with COVID is it does remain airborne longer and it travels farther than they had previously thought. So it is leading them to start to question, is the 6 feet an even adequate distance?
I do an educational piece in our newsletter once a week. It's an online newsletter. And I do talk about the benefits or the efficacy of wearing masks frequently and encourage it. I have signage at each door that says masks are required. And I address that's not a suggestion, it's a requirement. But I will not be the COVID police. And so occasionally there's one or two people who do not want to comply. But for the most part, I would say our congregation's been very compliant with everything that I've put in place as safety measures.
Bishop Amy, there was one question about the Synod's stance on small group gatherings. Do you want to kind of explain about the Synod's stance or policies or recommendations so that's a little more understandable?
Yeah, with the statistics that were involved in the first presentation about the counties, and thank you for that, Kim. We know that all of our congregations are in their own unique contexts, based in communities where things are not just the same across all our 132 congregations. And that's why, well, our polity as a church is certainly that every congregation has their own autonomy. And that's why we have really encouraged every congregation to have a SMART team so that you are in communication locally with your schools, that you are checking the CDC website, that you know what the Minnesota Department of Health, and thank you, Kim, for mentioning also school, the state school department. And did you put, okay, yeah, you put a couple of websites up for folks.
I did
Yeah.
put that up there, and somebody had asked for the documentation of transmission and it resulting back to church events and attendance. So I put up a couple articles there.
And I think if you
good.
just going to the CDC website and the MDH website, they have just tons of information. You might have to search a little bit for it, for the specific area that you're looking for, but it's there. And they have many great educational resources you can use and posters that you can print to put around your church for educational purposes.
And we know that by having congregational SMART teams, then there's that many more people who are becoming informed and are aware and who have relationships built already within the congregations with people who may need a little extra encouragement or who may also need some further information. And so having a SMART team within your congregation is a way to say, this is who we are in our community, and this is how we are going to be the church together here in our context. So it's not that there is, a synod stance. It's no, we're community together, we're the church together, and we're going to be about keeping as many of us healthy as possible. Yeah, weddings and funerals. There's Somebody's typed in that MDH, the Minnesota Department of Health, has specific information. We know that there are creative ways that are being approached for all sorts of gatherings. We know that ritual is important and that people want to be a part of you know, the milestones that people reach in their important times for family to be together, but there are creative things with technology and worship services that have incorporated people participating in reading lessons and in giving words at funerals, but that it is part of a video recording and part of the service. People have asked if you're willing to share your email addresses for any kind of follow-up. I think that,
Yeah, is it easiest to put it in the chat or, yeah, or if you want to send something out, but I'll go ahead and put it in the chat.
right. Do any smart teams find that your congregations don't accept your recommendations? Hard to have you speak to this, but some of us have found our councils take in what the team presents, but there's no follow through. And that's where we're responsible for being community together and encouraging one another. I don't know if other people have some examples of how you have dealt with trying to incorporate your smart team's recommendations in helpful ways.
I haven't had a problem with the council. They have agreed to go along with the recommendations of the SMART team. Again, some disagreement with a few members who have their own philosophy on whether herd immunity is the answer or that wearing masks aren't essential. But most of those individuals are not very confrontive and have preferred in the meantime, to just stay away. If they can't agree with coming to the small group and wearing a mask, they just don't come, which is unfortunate because we tried to get the small groups going to allow those people to have a connection to the church, but and to their friends. But I really have not had any disagreement from the church council.
I know it's been identified that the main thing is to really encourage one another to be compassionate and protect one another, love your neighbor. And I think too, when congregations see their support of their own communities and say, we're trying to support what our local schools are doing, I don't think that there's a superintendent or principal out there who wouldn't jump for joy knowing that the church is there to also support them in these difficult decisions too.
I think there was a question about a loss of members. Of course, we wouldn't know that until we start meeting in person again, but I do know financially people have continued to contribute. That our numbers that of the money that comes in each month is very good. So.
It is interesting because it's so varied by community. And I really can't discuss that one about the council and the teams because I'm too involved with that one. But in Grand Marais, we only have one church that is actually worshiping in person. All of the other churches are staying closed right now. Some have tried it, but everyone has gone to the fact that it's best to stay closed. One of the things that I've heard as arguments is we're meeting the legal requirements. We're meeting the legal requirements. And I have to say is, okay, maybe legally, but is that the right thing to do? Is that the thing that is best for the safety of our members? And it's down to that safety. And it's hard if you're in a congregation where people are thinking this is a hoax. It really is. And unless they've seen the stuff with COVID, experienced from those hospitals, people are going to have trouble believing that it's real.
Yeah, there's been some questions about folks who find it particularly difficult because other congregations in their community are open, and some of our ELCA congregations are taking a safer route. And that's the tough part about being community together. And I know that our pastors and deacons have met with ministerial associations and, tried to encourage one another to kind of have that common voice for the community. It is hard. It is hard. We all have our own polity and the way that we approach being a faith community. And so there is no magic bullet there. It's talk to neighbors, encourage people to care for one another in the cities and towns you live in. I think we all know that anxiety and tensions are high right now. People are tired, people are frustrated, and this is a time that most of us have never been through anything like this before, and it's not exactly bringing out the best in everyone. And so I think there again, encouraging, listening, hear the frustrations, hear the laments, but also, share love, share hope, and share concern for one another.
I tried to address that in one of my weekly articles and did one on mental health and how to stay healthy mentally and how to stay connected with people in your life when you can't gather, and listed resources if they were showing if they were feeling a great deal of anxiety and or depression or aloneness. And so I got positive feedback from that. I encourage everybody in all of our small groups to stay in contact, pick 2 people a day to call and check on them. You feel better after calling them. They feel better for having received a phone call. And that it's that personal contact that's important, even if you can't do it in person. So to have a caring ministry through a phone system. And before the weather got cool, I encouraged people to gather in driveways or even in our church parking lot outside to find ways to get together, to keep those connections of people they knew through church.
Yeah, there are so many creative ways that people are coming up with to gather together. And I know Good Shepherd in Duluth has a beautiful outdoor walking tour to take with a prayerful, meditative journey. People are doing, as you mentioned, parking lot services where if you've never done that before, it can be really comfortable as you sit in your nice toasty car and tune in and listen and can hear and turn it up as loud as you need it to be. Folks are doing opening, it sounds like opening sanctuaries for 10 minutes at a time and inviting people to register to come and be in sanctuary certain times during the Christmas Eve. Just sharing each other's best ideas and creativity is a way to spark some further joy in other folks. And I want to say too, we recognize that our pastors and deacons are trying as hard as they can to provide a plethora of opportunities for people to worship and be connected to one another and to God in this time. We know it's important to have that connection. And I want to encourage all of you who are council members and lay leaders in your congregations to take care of your pastors and deacons, because I know they're tired. They are tired. And many of them have not taken time away from their duties. And so be kind to your leaders and encourage them for some time off. And I think that you'll all appreciate healthy leaders in the future if you take good care of the people who are trying so hard right now. Brenda, are you seeing some other questions? Counting on you.
Yeah, people were just wondering if the chat was going to be recorded. Just talking about the age factor and risk of folks in our congregation. If I could just make a brief comment too, a lot of times our leaders hear that, oh, this is all political. And I think it goes beyond politics, obviously, to public health, but there's another side to it. I have a lot of family that are evangelicals, and they look at this from a totally different theological point of view. Coming from our Lutheran perspective, it's about love God, love your neighbor. There's a theology of glory out there with a lot of the churches that are open, that if it's God's time, then I'll go. So we're going to sing as loud as we can, hallelujah, or a number of them actually believe this is part of the end times in Revelation. So they have a totally different mindset than we do as ELCA Lutherans, where we want to protect the community, where we want to protect the neighbor, that this is how we show God's love. So again, for those who are refusing to wear masks or think it's a hoax, sometimes it's not political, sometimes it's their understanding of theology that, there's some opportunities for teaching and education on the theology of the cross, which we embrace as ELCA Lutherans, that Christ is indeed with us in those ditches and ruts and scary times of life.
I was just going to say, I was reading what Tracy said they were doing for Christmas, and then I saw Pastor Mark Dittmanson on, and I know that his church, Bethlehem and Grand Marais, they're going to do an outdoor bonfire for Christmas Eve. And Trinity is planning on the same thing, an outdoor bonfire. People can be in family groups. I would say, though, that even with that, people need to mask because distances are hard to maintain. And the benefit, it'll be cold. The mask helps keep your face warm. But that is a creative way that we can spend that time. And honestly, a bonfire in the middle of winter, doesn't that sound wonderful?
And just, let's see, a comment about having a space on the online reflections or someplace to share creative ideas for doing church is a suggestion. We just heard today that my hometown where I live is now the hot spot in St. Louis County, Cook, Minnesota. So it's, my husband and I went in for a test today at the Hibbing Armory, and you register online ahead of time. It was really well done, smooth, hardly, I mean, there was no waiting. We brought in our printed out papers, and we would encourage other people, if you're questioning, go in and get tested. So the National Guard did a good job.
Kim, could you bring up your slide again for the counties that are in our synod? I just think that kind of went by quickly. I think it might sink in a little bit more. At least it will for me.
Cook County was my low spot, but it could be that the data is a day lagged from where I'm pulling it from, right? These things can change so quickly. Yes, just give me a second here to get the right thing up and shared.
And our local grocery store had to cut back its hours because of employees that were sick. So, I mean, there's that other type of collateral that Kim mentioned earlier too, that people get affected by this.
And that's part of the concern too for the healthcare system, is that the staffing issues are challenging, because it's not just that the beds are occupied, but if the community is seeing high rates, then the nurses and the doctors and the respiratory therapists, they might be needing to quarantine or isolate because they were exposed, or somebody in their family was exposed. So this is Bishop Amy, which one did you want to see?
Next slide. I think that test positivity rates.
Okay. Yeah, so this is the test positivity rates in the community. And John, I believe you said these came from Medicare, and
This came from Medicare.
And I think you said it's tracking upward, at least in Cook and in some other counties. So that indicates more spread than we're catching. We're not testing enough people to get those numbers down below a 5%. And you can see, growing numbers of cases, although overall we're starting to track down again. And I think kind of maybe a good take-home message for this group is that people still need to be careful over Christmas holidays and seeing family and friends, and possibly opting for virtual for another major holiday. And I know that's hard, but it increases the chances of, to quote Mike Osterholm, that everyone will be here in the spring for Easter or for next Christmas. And so I think that's one thing to think about too, and getting tested and quarantining if you are planning to see family members who are outside your immediate household.
Yeah, thank you for bringing that slide back.
Yeah.
And since I am currently working in a healthcare facility, I do want to highlight this. The workers in a facility, especially in the more rural communities, we have a fear of a huge number of patients hitting us. And that is because we don't have the capacity to take care of them. So tonight on the CBS News, there was a report that said in Grand Rapids, Minnesota, Grand Itasca, their ICU is full, COVID patients. Their hospital is full. Up here in Grand Marais, we do not have an ICU. If you are sick and you need to be put on a ventilator, we have to ship you. But Duluth has literally been full. We have no place to send them. And that has happened quite a bit already. Up in this region, a person has gone into one of our community hospitals. They have needed to be sent to Duluth for more specialized care, and Duluth cannot take them. So these people have stayed in the community hospital. So far, I have not heard of any negative things happening from that. But that is a potential. And it is two things hitting in Duluth. One is the COVID patients. The second is from all the care that was put off when it was elective has now no longer elective. It's now emergency care for a lot of people. And our big referral hospitals are overloaded just in terms of the number of patients. Plus with their staff out, it's really hard. We hear up here a lot, Duluth cannot take patients. They are diverting. Where in the state could we find an open bed if we have to send someone? And so that is the other reality in the rural communities. And this is what makes the healthcare workers scared when we look at those positivity rates, when we look at the behavior of people out there.
That's a really good point. And I think both hospitals in Duluth have been on divert continually for a little while now. And I mean, of course, this is like a bed becomes available, a bed gets utilized. And so it's a little bit of a moving, but that 80% figure was for the state. So keep that in mind. And there's going to be differences all across that state. But John, that's a good point that people divert from rural areas to Duluth, and Duluth is full. And it also really is not good in terms of people who have emerging needs other than COVID, like heart attack or stroke. So I think that's also, there's a lot of ripple effects because of that.
And I will say too that we've had some instances where the Twin Cities hospitals have been trying to send patients to Duluth too. So when it gets bad around the state, we could be in the situation of North Dakota or South Dakota very quickly if we aren't careful.
All right, well, I think our people's questions been answered. Have we kind of come to a time where we can say goodnight? All right, I see thumbs up. Well, again, I'd like to thank our panel tonight, our Synod COVID Smart team, and thank you for sharing your knowledge and understanding with us. Thank you, everybody, for your questions. I think that it's evident that we need to gather as a Synod more often, and we will continue to invite you to some other times where we can get together and talk and learn from each other and share what's on our minds. So thanks for your time tonight. Thank you for being a part of this.
Good night.
You're welcome. Good night, everybody.
Good night.
Blessed Christmas to
Good night.
everyone.
You too.
Yes.